Postoperative nausea and vomiting is really a large unmet medical need. I think that while there's been a significant amount of research done over the last number of years to investigate new therapies, to try to look at combinations of therapies, and understand the patient population as best as possible, right now, up to 70% of patients that are at high risk for PONV still get PONV in the postoperative period. So there is a really large unmet medical need.
I think you're absolutely right, Ted, and it's still perceived as what we call the little big problem, so it still happens frequently.
I think that also, I want to add to that, TJ, is that PONV seems to be a real big problem for patients, and they continue to complain about it, they continue to focus on it, and makes this unmet medical need ever more important.
I think there are certain things that we can do to trying to reduce the risk of PONV. Identifying a high-risk population, for example, and using specific anesthetic agent that we know have a lower incidence of PONV, avoiding some of the narcotics, morphine type of medication, because we know that morphine is a significant risk factor for PONV, avoiding agents such as nitrous oxide, keeping the patient well hydrated, again a very inexpensive way to reduce PONV. And beyond that, I think it's important to consider specific medication to trying to reduce the incidence. In the last few years, our research has been trying to identify what are the various combination antiemetics that can reduce the incidence of PONV. And newer drugs, for example, can also have an impact in reducing these incidence further.
Do you think that there's any differences between inpatient surgery and outpatient surgery, or is there anything that we can do in those particular settings, in addition to what you just outlined, that might have an effect on the risk factors for PONV?
Yes, I think there are some differences between in and outpatients. While the incidence can happen both in and outpatients, but the impact can be somewhat different. For example, in day surgery patients, patients are expected to go home after surgery, and therefore persistent nausea and vomiting can keep them not only prolong their hospital stay, but sometimes they have to stay overnight in the hospital unexpectedly, and therefore that would disrupt their daily routine in the after surgery. Right. And beyond that, once they got home, if they become sick, not only that would disrupt their recovery process, right, but it also affects their caregiver, now having to look after them because they continue to have nausea and vomiting.
Just want to add also that for some patients, it's fairly distressful to have postoperative nausea and vomiting when they're discharged from ambulatory surgical centers or whatever, ever more making us think about how to really sort of prevent the long-term consequences or the long-term effects of PONV as well.
Absolutely. So Ted, from your research, what have you found out about the cause of PONV?
That's a really good question and a very difficult one, TJ. I think the pathophysiology of PONV is extremely difficult to sort of understand, and a lot more research needs to be done to really be able to put it in complete perspective and be able to understand potentially new targets and the right combinations of therapies that we have out there. Nevertheless, very similar to the context in other disease organs, for example, cough in the lungs and stress urinary incontinence in the bladder, that there's that the pathophysiology is probably due to a reflex mechanism between the gut through the nerves into the central nervous system and back out into the gut again. Using new tools such as the NK1 pathway have demonstrated to us the importance of the central mechanisms in modulating PONV.
Ted, it's so critical to continue this line of research because this is still a significant problem, and in fact our patient tells us that they really do not want to develop post-operative nausea and vomiting.
Yeah, exactly, TJ. I completely agree with you. And there's many other learnings that can happen from understanding post-operative nausea and vomiting. As I described before, the pathophysiology in many of the other disease areas really overlap, and so there are many learnings that can come from continued research in this area.
There are certain risk factors that we know for patients who are more likely to develop post-operative nausea and vomiting. For example, being female, one has 3 times the risk for developing PONV compared to men. Interestingly, being non-smoker, one has an increased risk for developing PONV. The use of narcotic pain medications such as morphine significantly increase the risk. Other anesthetic agents such as the inhalational agents can also increase the risk. There are other anesthetic agents that we know can reduce the incidence of PONV.
Has anybody done any research in the area looking for biomarkers of postoperative nausea and vomiting, or has most of the research have been done from a patient epidemiologic perspective?
I think there are some new studies that show that there are some genetic influences in the incidence of PONV. For example, one recent research suggests that the enzymes for the metabolism of the anti-emetics can influence the risk, can influence the incidence of PONV. When facing surgery, patients want to know what will happen to their surgery, and more importantly, how do they recover from that surgery process. So they want to know degree of pain, whether they are going to have nausea and vomiting after surgery, how long would it take to get back to their normal activities, as well as what they can do to try to hasten that recovery process.
How deep and how long do you usually spend with each of your patients, TJ, and what questions do you really ask them to try to bring some of these things out? Because sometimes people really don't tell you directly what's on their mind.
I think you're right, Ted. Patients are very nervous, especially before surgery. I think it's important that usually I spend some time talking to the patients, first of all, to try to allay their anxiety, to ask them what particularly concern them. In addition to that, I want to find out what are the risk factors, for example, to trying to avoid post-operative nausea and vomiting, because patients who have previous history of nausea and vomiting can result in an increased risk for developing PONV. And if you have history of motion sickness, that again can increase the risk. And I want to try to tailor an anesthetic that not only minimize the risk for developing PONV, but also specifically have a regimen to trying to reduce that incidence. For example, using a combination antiemetics, using a less what we call emetogenic anesthetic, by keeping the patient hydrated, for example, and keeping them calm and allay their anxiety. And that has been shown to be able to reduce the incidence of PONV after surgery.
Just wanted to follow up on that specific issue. So anxiety plays a big role in postoperative nausea and vomiting, and how do you address that, preoperatively or postoperatively?
Studies have shown that anxiety can play a role in PONV rate. And therefore, I think it's important, first of all, to explain to the patient and also trying to allay their anxiety. We normally give them a medication specifically to calm their nerve, and that has been shown to reduce the PONV rate. And post-operatively, one again has to explain to the patient how the surgery went to try and again allay their anxiety and help them in that recovery process.
If a patient does get PONV, suffers from PONV post-operatively, when are they most likely to get it? Early or late, both?
Well, most of the PONV occurs within 24 to 48 hours after surgery. But sometimes it can go beyond that. In particular, patients who have pain medication, such as the narcotic pain medication, which in itself can result in PONV, sometimes what we call the opioid-induced nausea and vomiting. So PONV, while most of it happens within 24, 48 hours, but it can also be prolonged to a much longer period. And this has significant impact in patients who continue to take opioids, for example, or those who have gone home beyond the hospital, and therefore they have to deal with that problem after discharge.
One follow-up question to that, TJ, is what are your views on the relationship of nausea and vomiting? Do they occur together? Do they occur sequentially? Is one early and one late? How do you see that?
Ted, that is a very interesting question. I think most people would agree that nausea and vomiting, although they are somewhat related, are actually a separate events. Some people may have nausea without vomiting, but very few people have vomiting without nausea. But we look at it as a sort of more separate event because there are some drugs which are better in treating nausea, others are better at treating vomiting. but both are interrelated as a problem.
For more information about products or services from Merck, visit Merck.com.